Professor Gossec is one of the most prominent and most important specialists in today's world of rheumatology. She is not only professor of rheumatology at Pitié-Salpêtrière Hospital, Sorbonne University, but also a well-known specialist. I'm sure that you are familiar with her work, but please allow me to remind you that Professor Gossec was involved in several research projects endorsed by EULAR. She has several research interests regarding rheumatoid arthritis, psoriatic arthritis, spondyloarthritis, patient-reported outcomes. She led successfully some huge EULAR project regarding the elaboration of new impact of disease index for psoriatic arthritis and rheumatoid arthritis. And she also led the task force who developed the EULAR recommendations for the management of psoriatic arthritis, both those from 2015 and 2020. She authored more than 300 peer-review manuscripts, so she has a very active activity in publishing, and also with EULAR she was involved in several committees, and she's also very active at the European level and not only. And I think that I could go on and on with the list of her accomplishments, but I will stop here. So it's a very important moment for us, and it's a huge honor and pleasure to have her with us, and I want to thank her because she accepted to be with us today. So dear Laure, the floor is yours, if I can say so. And thanks again for accepting to share with us some of your work. And we are looking forward to watch your presentation. Thank you again.
Oh, dear Andra, such a kind introduction. Thank you so much. And of course, you're well aware of many of my projects because they happen to be projects with you as well. So you've contributed in most of the wonderful things you just described. So it's a great pleasure for me to participate today because of the fact that we're such good collaborators and friends, but also because Romania is very close to my heart, as it is for many people in France. And I just want to say hello to all of you young colleagues from Romania. So. And thank you for inviting me. It's one maybe of the good sides of this horrible pandemic is that we, are developing more online interventions, and that's quite helpful. So I'm going to be discussing what to aim for in psoriatic arthritis, and more specifically the objective of remission. But please, I'd very much like this to be as interactive as possible, given the fact that I'm online. So if you have questions, please don't hesitate. Maybe, Andra, you can be my go-between and let me know if there are any questions in the room, because it's a bit difficult for me to check the chat box while I'm talking, but I'll be very happy to answer any questions during the talk or at the end of the talk, whatever is best for you. So these are my disclosures. So I do have a full-time academic and hospital position in Paris, where I've had the pleasure of also hosting some Romanian colleagues over the last years. And I've divided this talk into 4 parts. The first one is more generic, because I believe you are mostly young colleagues, and it's good to review how to assess psoriatic arthritis. And then we'll discuss more specifically remission, how to define it, and how far we should go in trying to aim for remission. And then we'll compare that with the patient perspective, because, well, that's important, and it's also a subject I work a lot on. So let's start by saying, why is remission of interest? Well, because remission is the proposed treatment target in psoriatic arthritis, and this is stated in different recommendations, most notably the European ones, such as the EULAR ones and the treat to target ones. And you see that the definition of remission is not totally clear, but it looks like remission relates to absence of signs and symptoms of infection. That's what it's about. So we already see that it will be a bit difficult to translate that into something that we can assess in our clinics, because there are many aspects to to this definition of remission. And if we want to include all of the signs of inflammation into a definition of remission, we have to think about what we'll be assessing. So, what would be the main thing that you want to assess when you're thinking about assessing inflammation in psoriatic arthritis? Unfortunately, I'm not with you, though, so I can't get anyone to raise their hands. But I do hope that you are thinking of joint counts, because psoriatic arthritis is, in most cases, an inflammatory disease of the peripheral joints, and therefore we need to aim for low joint counts. And I'm just showing this slide because I think there's still a little bit of debate around this. We're told that in psoriatic arthritis, you need to assess 66 and 68 joints rather than 28 joints. Well, this is the reason why. Because when you're only assessing 28 joints, you're missing around a quarter of the patients who have inflammation which is not situated on the 28 joints. And I think that's very important, because in rheumatoid arthritis, there is often inflammation which is not in the 28 joints, but there's a good correlation between the 28 joints of the DAS28 and the other joints, which is why it's widely accepted that you can do the 28 joint count in RA and not miss many patients who have inflammation. But I'm just showing you that's not the case in psoriatic arthritis. And that's a bit of a debate, because, it's a bit of a pity as well, because the DAS28 is something we're very used to and we know how to do, and now we're being asked to change the way we're assessing the joints. So this is the proper way to assess the joints in psoriatic arthritis. It's to do the 68 tender joint count and 66 swollen joint count. And this looks pretty scary on this figure, but I can assure you it doesn't take very long, and you're probably already looking at the feet, so it's just about checking the metatarsophalangeal joints, but also the proximal and distal joints in the hands, and the IP joints in the feet, and then you basically have reached 66, 68. So you can let me know at the end, or if you have any questions or comments about the feasibility of this. And then psoriatic arthritis is a more complex disease than just joints, which is why if we're thinking about minimizing inflammation, what else should we be assessing? Well, we need to assess what's recommended to be assessed when we're looking at disease activity. And this is the OMERACT Core Set, which was recently updated. And so the inner circle is what we should be assessing in all randomized controlled trials, which is a bit different from our clinical practice, but still gives us an indication. The second circle is things which it would be good to assess, and the third circle outside is about research agenda, things we don't know a lot about. So what I put here is I translated for you, if you want, what is meant by MSK, musculoskeletal disease activity, and then skin. So for musculoskeletal disease activity, we need to assess the joints, as we've already done, but the three other components are here: enthesis, spine, and dactylitis. Now, this is true for randomized controlled trials. For our clinic, I would like to suggest to you that doing the enthesis and the dactylitis is enough, because spinal involvement is quite complex in psoriatic arthritis. Sometimes people have pain in the spine, but it's of mechanical cause. And if they really have a lot of inflammation in the spine, of course you need to assess it. But if not, it's not a key element. And also it's quite difficult to assess clinically inflammation of the spine. So this is what is proposed in the as measures to assess the different inflammation components, if you want. Just showing it here so you can have an idea. You can see that for enthesitis, there is some disagreement as to what is the best score. And also for the skin, there are many ways to assess the skin. So joint counts are definitely the simplest in this summary of the different scores which exist. And this is my own personal proposal for what to assess in your clinical practice when you have patients with PsA on top of the joint counts. For the enthesis, I suggest to use the simplest score, which is the Leeds enthesitis count. It only has 6 joints to assess, which you can see here in the little blue circles. And therefore, the total score goes from 0 to 6, not 1 to 6, as I mistakenly wrote here. 0, you have no pain on pressure of the enthesis, and 6, you have pain on all 6 of the entheses at pressure. So it's a clinical examination score, which is better than asking patients if they have pain, because pain in the enthesis is quite frequent and not very specific. And then the other things which you should be assessing in your clinic are dactylitis, and that would be the number of digits which have dactylitis. And then you do need to assess psoriasis. PsA is a quite complex score, which is used by our colleagues in dermatology. But my proposal for you is to use the body surface area. In your daily clinics, it's quite easy to say if there is no psoriasis, very low psoriasis, less than 3 times the surface of the palm of the hand, then that's 3%, and then very extensive psoriasis. So that makes it very easy, and that allows you to reproduce your clinical examination and have something quantitative in your clinical charts. And then also the number of nails with psoriasis. And for me, that's good. You've done your clinical examination fully. How about what's important for patients? Well, this is what OMERACT recommends. The ones which OMERACT says are the most important are pain, patient global, physical function, such as using the hack, health-related quality of life, fatigue, and then systemic inflammation means CRP and ESR. And my suggestion for your practice is to do at least pain and patient global assessment. We need those 2, as we'll see later on. So that's my proposal in terms of what to assess in psoriatic arthritis. And going back to remission, well, remission is recommended as a target, okay, but do we have any data showing that it's important to aim for remission? In fact, we do. We have the TICOPA trial, which was published in the Lancet in 2015, when you guys were still in high school. So the TICOPA trial was the first and is the only to date tight control trial in psoriatic arthritis. And as you can see on the histogram, because I can't remember if you see my arrow on Zoom or not. As you can see on the histogram, the outcomes in the tight control group were always better than the outcomes in the standard care group. And in this specific study, the tight control group was driven by reaching for minimal disease activity, which we'll go back to later on, indicating that patients do better if you try to be rather harsh with their disease and try to increase the treatment if needed until you reach a good control of the disease. So we should be aiming for remission, but we still don't know exactly what remission is. And so let's look now at the definitions of remission. So to define remission, it's quite difficult because there are many composite scores. As we'll see right now, there are 2 which have been recommended more specifically and which I'll go back to later on. This is a little overview of the different scores, composite scores which exist in psoriatic arthritis. And as you see, we can talk about at least 8 scores, and this is probably not a full list. The ones I want to you to concentrate are the first line, which is the DAPSA. The DAPSA is a little bit like the CDI, the Clinical Disease Activity Index in RA. So it's a simple sum of joint counts, pain, patient global, and acute inflammation in the blood test. And then the other one I want you to look at is the DAS28, because you know that one. So you can see that the DAS28 actually looks quite a bit like the DAPSA, except of course it only has 28 joints, and also it uses an algorithm to calculate it, which is not just a simple score, a simple addition. And then I'd like you to look at MDA VLDA, because you see that one is quite different. It also has the skin, the light blue column. It has the enthesis as well, the green column. So that one is more complete if you want. And then there are other scores which are even more complete, like the CPDI, but which are quite difficult to do in clinical practice. So we see that, in fact, there's quite a bit of disagreement about what it means to be in remission. Does it mean having no swollen joints, or does it mean having no enthesis, no actual pain, and so on and so forth, and having normal patient-reported outcomes? Well, I don't have the full answer to that, but I can tell you where we stand for now. The treat to target recommendations have stated that there are two definitions which are of particular interest and need to be further studied. And these are the two we've just discussed, which is VLDA, MDA, and DAPSA. And I'm putting them here for you so that you can check them out. You can see that very low and minimal disease activity is actually a binary state. If you have all of the 7 scores below the cutoffs, like maximum 1 tender joint, maximum 1 swollen joint, and so on, for all 7 of them, you are in very low disease activity. If it's the case for 5 of the 7, any 5 of the 7, you are in minimal disease activity. And if one of them is above, then you are not. It's just you are or you are not in VLDA and MDA. And the DAPSA is quite different because it's a continuous score. It goes from 0, if you have 0 tender swollen joints, 0 for pain, patient global, and CRP. And it goes quite high because the tender and swollen joints go up to 66 and 68. The pain is a 0 to 10 numeric scale. The patient global is a 0 to 10 numeric scale. And the CRP, careful, it's in milligram per deciliter, but that can go as high as needed. It's just a simple sum of the different components. And you are defined as being in remission if you have a maximum of 4. For example, if you have 1 tender joint, 1 swollen joint, a pain of 1 out of 10, a patient global of 1 out of 10 in a normal CRP, you are in remission, okay? And for the VLDA, MDA, if you have 1 tender joint, 1 swollen joint, no skin involvement, and low pain in patient global, you are also in VLDA. So that gives you a little bit of an idea. So these are the two definitions. And as you see, there are many elements which are in the middle box, but MDA includes enthesitis, skin, and also the HAC, which is a difficult element because the HAC is not very sensitive to change, meaning if you have long-standing psoriatic arthritis, it is quite frequent to have a high HAC, and it will not get better even if you control the inflammation because the HAC reflects both inflammation and damage. And DAPSA has CRP, which the MDA, VLDA does not have, okay? So these are a little bit of these two scores. And we'll see a little bit later on that both of them are related to better quality of life. I would say that for now, we are lacking still hard data showing if one is better than the other in terms of radiographic damage, which would be very important to know that you're preventing damage for your patients. And I also show this slide because I think it's quite interesting to compare to the Boolean ACR-EULAR remission definition. Because, dear colleagues, as you probably know, the Boolean definition is felt to be very strict in RA, and it is said that patients with long-standing disease, probably not more than 10% of them or so are reaching the Boolean remission. Well, let's look at the VLDA here on the right side. You can see that it's even stricter because you now have the same limits for swollen and tender joints, but you also have more patient-reported outcomes which have to be normal, and also the HAC has to be normal as well as skin and enthesis. So what I'm saying is we're probably aiming very low in terms of inflammation when using the VLDA and even the MDA, and probably the DAPSA is a little bit more permissive. But this is more of a philosophical question for you. How low should we go for inflammation in psoriatic arthritis? And we'll try to answer that in the next few minutes. This is a little bit peripheral, but those of you who are interested in randomized controlled trials, you will see in the green boxes here in the middle which scores have been used in recent PsA trials. And you can see that for now, it looks like the MDA is winning, if I can say, because the MDA has been used in most of these trials, VLDA much less, and DAS28 is still very widely used in PsA trials because pharma companies are getting a bit lost because we have so many scores and we have not yet reached a full consensus that they say, okay, you know what, let's take DAS28 because we know that one. So that's what's happening in trials right now. So I've just shown you the two key definitions. And now let's look at which one is the most stringent or the least stringent. And the first paper which really gave nice data on that was a paper by Laura Coates in the UK, published in 2018 in ARD. And as you see here, in this first study of patients from the Netherlands, we could see that among patients who were already doing well according to the rheumatologist, it was much more difficult to reach VLDA. The two on the left are definitions of remission. The two on the right are cutoffs for low disease activity. It was much more difficult to reach VLDA than DAPSA remission, about half of them, and also much more difficult to reach MDA than DAPSA low disease, though the difference was more around 1/4 of them or something like that. So that was the first indication we got that maybe the VLDA and MDA are very strict. And last year we performed with my fellow a systematic literature review, which was recently published. And I'm showing you this. This was a systematic review of 185 studies in psoriatic arthritis. 1/3 of the studies were reporting either remission or low disease. And as you can see on the left part here, and that's the first interesting element, is that VLDA MDA, the black bar, is much more used in published studies than DAPSA, which is the second bar. And in fact, the second most used score after VLDA MDA in studies published over the last 5 years is DAS28, as I was saying earlier. And then on the right part of the graph, you can see the frequency according to the definition. I just want to show you here the DAS28, which is the light gray bar. And you can see that DAS28 is much less stringent, both for remission and low disease, than the other two scores, VLDA and DAPSA. And I'll show you again here the VLDA and DAPSA meta-analysis frequency. You can see that in these studies, you only have 13% of very low disease activity. You only have 23% of DAPSA remission, and low disease is more feasible, but it's a lot more feasible with DAPSA than with minimal disease activity in these studies at least. So basically what we're saying is that VLDA and MDA are very difficult to reach. But that doesn't tell us which one is the best, okay? It just tells us, well, depending on how low you want to go, if you want to aim for full disappearance of inflammation, you should probably go for VLDA, or for low disease, you should go for MDA. If you just want to go for a state which probably doctors think is okay and which minimizes inflammation, then you can use the DAPSA. The DAPSA is easier to use in clinical practice because you don't need to look at the skin and the enthesis. And I would like to say in defense of the DAPSA, because it looks like it's less complete as a score, that maybe what we're aiming for long term is to protect the joints of our patients. At least that's something which is very important for me as a rheumatologist. And the ultimate damage to the joints is really related to the joint count, so to the number of inflamed joints, and to the CRP. And that's exactly what DAPSA looks at. Having a lot of skin involvement is really not comfortable for the patient, but it will not lead to more damage. Neither do entheses. Entheses hurt, but they don't lead to damage, to permanent damage. So I think that's the reason why I feel that DAPSA sort of better encompasses the idea of inflammation leading to damage, but does it correspond to what the patient thinks is important? That's what we'll look at over the next few minutes. And so I have too many slides on this, so maybe I'll have to go quickly on this one, but it's important to align targets with our patients because, you know, I guess if you all chose rheumatology, it's because you want to make patients feel better. I know for sure I did. If I was just interested in MRI, I would be a radiologist, right? So, you know, we want our patients to feel better. That's the ultimate goal, and we want them to feel better long term. So maybe for us, that would mean simply just the DAS28 remission. Maybe that's already enough. Maybe it's the DAPSA remission, or maybe it's minimal or very low disease activity, which is less stringent. But let's try to align this with what the patient wants. When you ask a patient what they want, they just want to feel good and they want to have a normal life. That's what they basically want. And when we look at this systematic literature review, which was performed by a Romanian colleague and now working in Cambridge, UK, hello, Tanya, you can see here some of the things which are important for the life of a patient who has PsA. And I'm sure you think of pain and function as key aspects, and that's indeed true. But look at all the other things which are important for patients. PsA is a difficult disease to live with because it alters the way you see yourself, the way people see you. You get like a double penance. You get the joint disease, but you also get the skin disease. You don't want to go to the beach because you have psoriasis on your skin. You don't want people to look at you. You think your husband will leave you. And, you know, you're just basically, it's a difficult disease to live with, as you can see from this slide. So what's important for patients? Well, we don't really have that many studies in psoriatic arthritis, but we do know this for RA, is that when you ask a patient, what does it mean to be in remission? He or she will certainly not say having no swollen joints and a normal CRP. He or she will say, I want to be normal. I want to have no impact of my disease. I want to have no symptoms. So you see here that there's this discrepancy between what we're saying to a patient and what they hear. We're saying, I'm going to put you into remission, and they hear, I'm going to go back to my life before. When you mean you're not going to have swollen joints anymore. You see how difficult communication is? And I'm going to skip these ones. This one just says that in around a quarter of the visits, we don't agree with our patients on how they're doing. And this one says that one of the aspects for that is fatigue, because many patients are very, very tired when they have PsA. And some of that is not related to the inflammation, but they still want us to make it better. So going back to the idea of what do patients want? They want better health-related quality of life. And what I'm showing you here is data from an international study called PsA, which is run by Janssen. And in this study, we looked after 6 months of treatment with any biologic, basically. We looked how patients were doing in everyday life, if you want, real-life data from PsA patients. And you can see here that firstly, that it's feasible to reach for low disease activity. That's the blue table on the left. You can see that remission is reached in around 20% of patients who are receiving one of the biologics. And CDAPSA, low disease, is reached in about half of the patients. VLDA, again, is more strict at 10%. And MDA, again, is more strict also than CDAPSA LDA at around 30%. But that's still reassuring, isn't it? When you take patients who have long-standing disease, you give them a biologic, around half of them will be in low disease after 6 months. And then on the right, what I'm showing you here is, do they feel better in terms of quality of life if they reach remission? And the answer is, lucky for us, yes, they do. If you look on the left part of that graph, you have the CDAPSA remission and low disease. So here we are pooling patients who are in remission, low disease as yes, or no remission, low disease as no. You can see that they're doing much better in terms of overall quality of life in the yes group. And then for VLDA, MDA, again, they're doing much better. They're in fact doing even better in the VLDA, MDA group, but the confidence intervals overlap. And also remember that only half of the patients in CDAPSA remission or low disease are in VLDA, MDA. So it just makes it more stringent, but it does improve at least as much or more the quality of life. And then we ran with Professor Balanescu and other colleagues this really nice study called the REFLAP study, where we actually compared these two definitions of remission, VLDA, MDA versus DAPSA remission or low disease, to asking the patient how they felt. And we asked the patient, do you feel in remission or do you feel in low disease activity? And in these 400 patients, you can see again, we confirm, of course, that VLDA, MDA is more difficult to reach on the top than DAPSA remission low disease in the middle. But what I found interesting is that when you ask patients how they're doing, they actually think they're doing pretty well. As you see here, almost more than 60% of them said they were either in remission or in low disease. So maybe we all think patients are asking for too much, but in fact here, they said they were doing pretty well, even better than the doctors thought they were doing. And this is the key finding from that study, is when we crossed over the two definitions of remission, on the top VLDA MDA, which is the blue circle on the top, and on the bottom DAPSA remission LDA, blue circle on the bottom, against patient perceived remission or low disease, which is the light blue circle on the right, you can see that there was better overlap with the DAPSA definition of remission or low disease on the bottom, because the DAPSA remission encompassed more patients who thought they were doing well. There are still 72 patients who thought they were doing okay, but they were not in remission. Whereas on the top, the VLDA MDA is very restrictive and therefore missed almost half of the patients who said that they were already doing pretty well, which means that the performance of the VLDA MDA against the patient perspective used as a gold standard was lower than for DAPSA. So that still doesn't tell us which one is the best, but it does give us some information about what our patients are aiming for at least. So dear colleagues, to conclude this talk, I'm running a little bit over time, but I hope that's okay. You know, remission in psoriatic arthritis is definitely still a moving subject. It's something where we need more hard data on what it means to be in remission and how you can reach this remission and how long you stay in remission and what it means for radiographic outcomes and for quality of life. But at least we are starting to see a little bit more clearly that there are two different philosophies, if you want. One is to attack the disease through the joints and the CRP, and that would be using DAPSA. And the other one is to attack the disease as a more global entity, including the skin and the enthesis, and that would be VLDA MDA. You know, we've seen that VLDA MDA is a lot more strict than DAPSA remission low disease. And I want you to ask yourselves how low you want to go for your patients, also taking into account, of course, the benefit risk cost ratio of our treatments today. You know, if the patient still has one painful joint and the pain is at 2 out of 10 for a patient with long-standing disease, that patient will not be in minimal disease activity because of the pain at 2 out of 10. Do I still think that patient is doing fine? I have to say I might well think that, and I may not want to switch or change biologics, but this is a personal decision for you. We don't know exactly how to do tight control right now, and we also don't know very well how to deal with situations of discordance between the doctor and the patient, which I did not have a lot of time to talk to you about, but maybe I will be invited next year and we can discuss that then. So I do hope this has given you some indications for your practice tomorrow with your patients. I'd like to thank you and say hello from sunny France and Notre Dame. And I'll be very happy to answer any questions you may have.
Thank you very, very much, Laure, for this very comprehensive and interesting presentation related to this field, which is very active and dynamic, the assessment of remission and PsA. And first of all, I think we all agree that we should give a big round of applause
Thank you very much.
Professor Gosek. Now, my dears, do you have any questions to address to Professor Gosek? Yes, Lavinia, yes, please.
Hello, I'm Lavinia Rusu from Bucharest. I have one question for you. How useful do you think technology is in assessing disease activity by patients with psoriatic arthritis? I mean, the so-called electronic patient-reported outcomes tools. How useful do you think they are?
Thank you. That's a great question, Lavinia. Thank you for asking me that. And also, just when you said that, I was thinking also of technology using ultrasound. So just a word about ultrasound first. I don't know if many of you are using ultrasound in your clinics. I think ultrasound is probably a very helpful tool to assess also subclinical inflammation in PsA. But for now, we don't have any data in PsA showing that it's useful to follow patients on ultrasound. So it's still a field in progress as well. And now to answer your question about technology for PROs, which is a subject I'm really interested in, so thank you for raising that. I would say that it's still a little bit on the research side for now. So we don't currently really know exactly what we should be asking patients if we do regular assessments from home using EPROs. For example, should you ask them for pain? But how about if they always have pain, you know, so that's not a change? Should you ask them if they're flaring? Because flares are what we want to avoid, because flares lead to damage. Should we ask them to self-assess their quality of life? It's not very clear for now how helpful these results are for our clinics when we see the patients. So I think it's still a little bit of a field in progress. Also, I would like to use this opportunity to address the difficult question of these patients who will report on their PROs or their EPROs that they're not doing well at all, but you in fact think there is no inflammation. So in that case, I personally recommend to not change the treatment based only on PROs. I mean the disease-modifying treatment. You can change the symptomatic treatment. You can maybe do joint injections if that's needed. You can send them to see a psychologist. You can put painkillers, a lot of things, but not change the DMARDs, because that's when we end up with difficult situations, patients who are failing drugs, and we don't know exactly where we stand. So for now, EPROs are still a matter of great interest, and hopefully we'll know more within a few years on that.
Thank you very much, Laure. Are there any other questions from the audience? Yes, please.
Hello, Christina from Craiova here. I would like to ask you, how does fibromyalgia affect disease activity scoring, and how can we flatten its influence? And also, can we still use DAPS or VLDA scoring in patients with both psoriatic arthritis and fibromyalgia?
Oh, thank you. That's a great question as well. Thank you very much. Yeah, this is a really complex situation, which is what I tried to touch on briefly regarding discordance of assessment, is those patients who just have pain everywhere and even high painful joint count, but in fact what they have is fibromyalgia. And we know that the prevalence of fibromyalgia in inflammatory rheumatic diseases is around 20%, which is really high. And it does indeed make it very complex. So my first suggestion would be that if we feel there is maybe fibromyalgia or fibromyalginess, as some colleagues call it, one useful score, which was developed a few years ago by some colleagues, is the FIRST score. So I don't know if you use this a lot. It means FI for fibromyalgia rapid screening tool. So FIRST, it's available online. It's free of use. I don't think it's validated in Romanian, but it might be. I don't know. And so it's a very simple questionnaire with 6 questions. If you answer yes to 5 or 6 of the 6 questions, there's a good chance that you have fibromyalgia. So that, for me, I use it quite a lot in my clinics, because they're not aggressive questions. They're not horrible questions about did you have problems with your dad when you were a kid, and anyway, blah, blah. So these are just questions about the spread of the pain, They're easy for the patient to answer, and they give you some indication. And then what to do with it? It's very difficult. And of course, you're right. It does make our assessment very, not exactly unreliable, but skewed, biased towards higher joint counts. I would say that I would believe the swollen joint count in any case. And I have to say, for me, swollen joint count is really the key of what I'm trying to aim for, because, again, that's what's linked to further damage. The painful joint count is very difficult to interpret. The enthesial joint count, the enthesial count is almost impossible when you have fibromyalgia. So, some defenders of the enthesis, like Dr. Daphne Gladman in Canada, she says, oh, it's very different. When you have fibromyalgia, you have a little bit of like overall pain and muscle pain. When you have enthesial pain, you have pain right on the enthesion. That's very easy to see. I have to say, in my clinic, I don't find the distinction so easy to make. I don't think there's any way to answer you to minimize the impact of that. But I think it makes perfect sense to put in your medical file, inflammation is minimal or absent for swollen joints and CRP and maybe then ultrasound. And although there are many painful joints, I will not change the treatment because of the fibromyalgia. What I mean is we should adapt this target according to the fibromyalgia of the patient. And it's very difficult. What I do think is a good sign is that sometimes it's not a lifelong condition. Patients can be flaring and then they get fibromyalgia, and then they do better, and the sort of widespread pain aspect gets better. So that's a little bit of hope for them, because fibromyalgia is so depressingly chronic. But fibromyalgia associated to inflammatory rheumatic diseases does not appear to have the same, lifelong story. So that's a good sign.
Thank you again. Are there any other questions from the audience? Well, if you allow me, I will also want to address you a question. Psoriatic arthritis is a systemic inflammatory disease, and we know that many of our patients have a lot of comorbidities. On one hand, we do have some evidence-based recommendations for the management of several immune-mediated traumatic diseases, including psoriatic arthritis, but still we don't have a good index to evaluate comorbidities. But if we are thinking to a comprehensive and profound assessment of remission in psoriatic arthritis, beyond skin and beyond the joints, shouldn't we include also, or try to include, the assessment of comorbidities? This is the internal specialist in me speaking.
That's a really tough one, Andra, because then that makes it even more ambitious and more difficult, I would say. But you're right. I think it's really important to address the comorbidities, because the patients will not die of their PsA, but they may well die of their cardiovascular untreated comorbidities. Usually, I would say I see it as two things. The inflammatory remission, meaning no more inflammation, and then also the minimization of the comorbidities. As you know, but maybe some of the colleagues in the room or by Zoom don't know, the inflammatory part of the process explains around 50% of the cardiovascular risk in those patients. So just by minimizing inflammation, you will already be treating part of the comorbidities, at least the cardiovascular ones. But then for what's left, I think we need to consider it separately and look at the other risk factors, and also look at the risk of infections and so on. But indeed, you're very right. We need to be more global than looking just at the inflammation, and for sure take care of comorbidities. I think you had a talk, don't you, on for comorbidities?
We had during the morning, we talked about cardiovascular risk and metabolic syndrome, and of course this is a topic that is of high interest for all of us.
Yes.
So are there any other questions? If not, please allow me to thank again Professor Gossec for spending this wonderful hour with us, and to thank her for her amazing presentation and all the great information that she gave us. And I really hope that in the future we will have the opportunity to welcome you, Laura, in Romania. There are several wonderful places here as well. And maybe next year, or I don't know when, we will have the opportunity to have you here with us. Thank you again.
Thank you so much, Andrea. It was really a great pleasure. I've been looking forward for a long time to come and give a talk in Romania. We've been talking about it for years, so I'm here virtually. But again, thank you so much for inviting me. And don't hesitate to send me an email if you have another question, one of you younger colleagues here.
Thank you.
Maybe I'll be able to host one of you in Paris someday. So, Andrea, thank you so much. Take care.
Thank you, and let's give her another round of applause from our hearts.
Thank you.
Bye bye, Lor. Bye bye.
Bye.
Ok. Sper că v-a plăcut. Lor e o persoană deosebită și cred că ați simțit-o și că e o persoană caldă, deschisă, deși este extrem de celebră și n-am exagerat cu nimic când am prezentat-o, dar este o persoană caldă, deschisă. Dintre rezidenții noștri ați auzit, au fost și au lucrat cu ea, i-a implicat în proiectele ei de cercetare, au publicat împreună cu ea. Deci chiar, dincolo de faptul că mie personal îmi este foarte dragă, chiar este o personalitate marcantă și merită să ținem legătura cu ea din punct de vedere profesional. Așa că sper că v-a plăcut această sesiune. Ziua de azi a terminat. Sigur, nu poți să epuizezi subiectul artritei psoriazice într-o zi, dar am încercat să alegem câteva aspecte care poate au fost mai puțin dezbătute până acum sau care poate au suscitat un interes mai deosebit, așa că eu vă mulțumesc foarte, foarte mult pentru participare și pentru prezență și restul zilei vă aparține și vă doresc de asemenea în continuare câteva zile minunate, pline de informații interesante, dar și de puțină relaxare și odihnă. Vă mulțumesc și o după amiază minunată!